Welcome back to the deep dive. Today we are really digging into a pretty dense stack of sources, all focused on dermatology.
Yeah, it's a big topic. Skin conditions can be confusing.
Exactly. So our mission, really, is to give you, the listener, a solid framework, like a clinical cheat sheet, for understanding, telling apart, and spotting the key features of these conditions that often get mixed up.
It's easy to see why they get mixed up. I mean, the skin, it's our largest organ, right? And it reflects so much about what's going on inside.
Totally. So we want to move past the heavy jargon and pull out the clinical insights you can actually use.
Right. Whether it's a blister or maybe just a dry patch or some kind of spreading rash,
Yeah.
that lesion is often the first sign, the visible clue to something deeper. It could be a simple barrier issue, could be, a major immune system problem.
Precisely. We want you to have that kind of aha moment when you see a rash. To quickly think, okay, is this mainly an outside problem, like a barrier breakdown needing moisturizer?
Mm.
Or is it internal, maybe autoimmune, needing systemic treatment? Or, is it something infectious, an emergency?
We're covering that whole spectrum today, starting with the more common chronic stuff and then moving into the really critical conditions.
Okay, let's dive in. All right, so starting point. Conditions where the main issue is, like the skin's physical structure being compromised. First up, nummular eczema.
Nummular eczema, yeah. The sources call it idiopathic, which, just means we don't know the exact trigger.
Right, so what's the visual, the thing that makes you recognize it right away?
Well, the name itself is the clue. Nummular, like a number or coin,
Yeah.
from the Latin. So you're looking for these chronic, really itchy, pruritic round, coin-shaped plaques.
Coin-shaped, okay.
Yeah. They're usually scaly, sometimes they crack or fissure. And critically, they tend to pop up on the extremities. You see them a lot on the lower legs, especially in people who say their skin is just chronically dry.
And the sources emphasize that link to chronically dry skin. That seems key for the pathophysiology nugget here.
It really is. The thinking is that when the skin gets that dry, you lose some of the natural lipids, the barrier gets impaired, like, tiny cracks appearing, and that breach triggers inflammation locally.
Okay, so understanding that cause the dry failing barrier helps tell it apart from lookalikes.
Absolutely. Think about what it gets confused with. Maybe a fungal infection, like ringworm, Tinea corporis.
Right, ringworm has that classic ring shape.
Exactly. Tinea grows outward, so the fungus is active at the edge and the center starts to clear up. Nummular eczema, it's different. The inflammation is pretty uniform across the whole coin shape. There's no central clearing. That's a huge tell.
Okay, that uniformity is key. Rules out fungus. What about psoriasis? That makes plaques too.
True, but psoriasis looks different. It really likes pressure points. Elbows, knees, scalp are classic spots. And the scale is different too. It's that thick, silvery white scale. Nummular eczema scale is usually drier, maybe less thick, and it prefers those dry extremities, not usually the pressure spots that help separate them.
Got it. So coin shapes, on dry legs maybe, no central clearing, think nummular eczema, and the management follows the cause, right? Barrier repair.
Precisely. The sources point to high-potency topical steroids, like betamethasone, to knock down the inflammation during a flare. But just as important, maybe even more so long-term, is the supportive care. Heavy-duty emollients, constant moisturization, avoiding harsh soaps. You've got to fight that underlying dryness.
Makes sense. Okay, sticking with this barrier integrity theme, let's tackle contact dermatitis. This one forces us to differentiate between two really different mechanisms, right?
Yeah.
Irritant versus allergic.
Yes, this is a really important distinction. They can look similar sometimes, especially if they become chronic, but the why is totally different.
Okay, let's break down irritant contact dermatitis, or ICD first.
So ICD is basically damage from repeated exposure. It's cumulative trauma, you could say. It's caused by things that aren't necessarily allergens, just mild irritants. Think frequent hand washing, detergents, solvents, maybe even just water over time.
How does that cause the rash?
Well, these irritants directly damage the skin cells, the keratinocytes, and they strip away the natural moisturizing factors in the skin, which leads to more water loss through the epidermis. The barrier just gets worn down.
It sounds like something you'd see in certain jobs.
Often, yes. Clinically, you see chronic dryness, scaling, the skin might get thickened, even fissured. And very commonly, it's on the hands and fingers. Think healthcare workers, cleaners, bartenders, people whose hands are always wet or exposed to chemicals.
And the big clue for telling it's ICD, according to the sources,
Depending how it behaves.
how it behaves.
Exactly. The symptoms get worse if you stop moisturizing regularly, but they improve with emollients, sometimes dramatically. Why? Because you're literally replacing the barrier function that the irritant stripped away. It's a straightforward mechanical or chemical injury.
Okay, simple cause, simple fix. Avoid the irritant, load up on moisturizer. Now, contrast that with allergic contact dermatitis, ACD. If ICD is trauma, what's ACD?
ACD is immunology in action. It's a specific immune response. Technically, it's a type IV hypersensitivity reaction. This is delayed, and it's mediated by T cells. Your immune system basically learns to recognize a specific molecule, an allergen, and then launches an attack the next time it sees it.
And that delayed part is really key for diagnosis, isn't it? The rash might pop up hours or even days later.
That's the tricky part. The reaction typically starts anywhere from 4 to 96 hours after you touch the allergen. And if it's the very first time you've ever been exposed, it can take up to 3 weeks for your immune system to get sensitized and react. So the patient might not connect the rash to something they touched yesterday or even last week.
What are the classic triggers we should know?
The sources highlight a couple of big ones. First, nickel. It's probably the most common contact allergen worldwide. You see it exactly where metal touches skin. Think belt buckles, snaps on jeans, watches, cheap jewelry, earrings. The pattern often gives it away.
And the other really memorable one, poison ivy.
Urshul, yeah. That's the oil in poison ivy, poison oak, poison sumac. The visual clue here is often quite striking. You get these linear streaks of rash.
My streaks.
Because the person brushed against the plant, or maybe they got the oil on their fingers and then scratched themselves somewhere else. It literally paints a line of allergen on the skin. The rash itself is usually intensely itchy vesicles, maybe even small blisters.
Okay, so the big aha moment here. ICD is barrier breakdown from repeated irritation, fixed by avoiding the cause and using moisturizers. ACD is a specific delayed immune reaction to an allergen, needing identification and avoidance of that specific trigger.
You got it. And that leads us nicely into the sort of cornerstone condition for barrier dysfunction, atopic dermatitis, what most people just call eczema. This one often has a genetic component.
It does. The sources mention a link to mutations in the filigrein gene. What does filigrein do?
Filigrein is a really important protein. It helps organize the structure of the outermost skin layer, the stratum corneum. Think of your skin barrier like a brick wall. The skin cells are the bricks, and filigrein is a key part of the mortar holding them together. If you have a mutation, the mortar is faulty.
So the wall is leaky.
Essentially, yes. It creates a defective, porous barrier. And that explains why atopic dermatitis is so strongly linked to what we call the atopic triad: eczema, asthma, and allergic rhinitis. It's not just dry skin, it's skin that lets environmental allergens, irritants, microbes get in much more easily, triggering inflammation.
Okay, so for spotting it clinically, location seems crucial, and it changes with age. Can you walk us through that?
Yeah, the distribution is quite typical. In babies, infants, you tend to see the rash on the face, the trunk, and importantly, the extensor surfaces the outside of the arms and legs.
Extensors, okay.
But here's a vital clue. The diaper area is usually spared.
Why is that? Seems counterintuitive.
Well, the diaper actually traps moisture, creating an occlusive environment that, in this specific case, sort of helps the barrier function right there. So, spayed diaper area in an infant with rash elsewhere points towards atopic dermatitis.
Interesting. And then as they get older,
As kids grow into adults, the pattern often shifts. It classically moves to the flexural, creases the inside of the elbows, the back of the knees, also the neck, wrists, ankles sometimes.
so location tells a big part of the story. And the management, regardless of age, starts with that barrier concept again.
Absolutely. Frequent, liberal use of emollients, thick creams, or ointments is the foundation. That's first line. You have to hydrate and protect that faulty barrier constantly. Topical corticosteroids are then used to manage the acute flares, the periods of intense itching and redness.
But there's a complication we need to watch out for, right? Secondary infection?
Yes, this is a major clinical pitfall. Because the skin barrier is broken, it's really easy for bacteria, usually Staphylococcus aureus, to colonize and cause an infection on top of the eczema. We call this impetiginization.
So how do you spot that? How do you avoid just cranking up the steroids when what's needed is an antibiotic?
That's the critical judgment call. If the eczema isn't getting better with the appropriate steroid treatment, or if it suddenly gets much worse, look closely. Are there new little bumps, vesicles? And especially look for golden or honey-colored crusts forming over the raw, eroded areas. That crusting is the classic sign of secondary impetigo.
Honey-colored crusts. Got it. That's the visual flag. So using more steroid on an infection would be bad.
Exactly. It suppresses the local immune response and can let the infection get worse. If you see those signs of impetigo, you need to treat the bacteria. For localized spots, the sources suggest topical mupirocin ointment. If it's more widespread, the patient might need oral antibiotics. Recognizing this prevents ineffective treatment and potential steroid side effects.
Okay, that feels like a good transition point.
Yeah.
We've covered conditions where the issue is primarily, you know, external damage or a faulty barrier.
Yeah.
Now let's pivot to disorders, where the skin is more like a billboard, showing us something deeper, maybe an autoimmune attack or a systemic disease.
Right. These are where the body's own immune system is driving the inflammation and damage. Let's start with discoid lupus erythematosus, or DLE. This is a form of cutaneous lupus, meaning it's often limited to the skin, at least initially.
What makes DLE stand out? It's not just a simple rash, is it?
No, definitely not. Its hallmarks are its location and its tendency to cause permanent damage. You typically see these well-defined erythematous, scaly plaques, and they have a strong preference for sun-exposed areas. Face, scalp, ears are very common.
And the damage part.
That's the key. As the inflammation continues, DLE actively destroys skin structures. The lesions progress to cause skin thinning, atrophy, permanent scarring, and often central hypopigmentation. A loss of color in the middle, surrounded by a darker rim of hyperpigmentation. If it hits the scalp, it causes scarring hair loss, which is irreversible.
Wow. Okay, so that scarring is a really important feature, setting it apart from, say, eczema. But beyond the cosmetic impact, there's a bigger concern, right? The systemic risk.
This is absolutely critical. You can't just treat DLE as a skin-deep problem. The sources warn that a significant percentage, maybe up to 30% of patients with DLE, might eventually develop systemic lupus erythematosus, SLE.
So finding DLE means you have to watch for SLE.
Yes, especially if the DLE lesions are widespread, or if the patient starts developing other symptoms like joint pain, fatigue, fevers, or if their blood tests, like the ANA titer, become positive. You have to monitor them closely for potential progression to systemic disease.
So management has to reflect both the trigger and the risk.
Yeah.
Aggressive sun protection is paramount, obviously.
Absolutely fundamental. Plus, high-potency topical corticosteroids are usually the first line for the skin lesions themselves.
Okay. Moving from destructive plaques to some very unique papules. Lichen planus, LP. This one has a memorable description.
It does. LP gives us one of dermatology's classic mnemonics, the 5 Ps. The lesions are typically pruritic, itchy, purple or pinkish purple, polygonal angular shape. They start as papules and can merge into plaques.
Where do you usually find these P lesions?
Often on the flexor surfaces, like the inner wrists and ankles, but the real diagnostic giveaway isn't always the skin papules themselves. It's often something called Wickham striae.
Ah, those fine, lacy white lines.
Exactly. They look like delicate white webs or networks on the surface. You can sometimes see them on the skin papules, but they are particularly characteristic and often the first sign when they appear on the oral mucosa inside the cheeks, on the tongue, or gums.
An oral LP can be a problem in itself.
Yes, it can be chronic, cause a burning sensation, make eating uncomfortable, and it needs monitoring because there's a very small risk of it transforming into oral cancer over time.
Interesting. Another feature mentioned is the Kubner phenomenon. What's that?
That's where new lesions appear specifically at sites of minor skin trauma, like a scratch, or along a surgical scar. It tells you the underlying inflammatory process is highly reactive to physical stimuli.
Just like DLE had a systemic connection, LP has one too, but it's different, right? It's linked to an infection.
A very important one. Lichen planus has a strong association with hepatitis C infection. It's so strong that current guidelines recommend screening every patient diagnosed with LP for hep C. Treating the underlying hep C, if present, can sometimes lead to improvement or even resolution of the LP.
Wow, that's a crucial link to remember. Skin rash triggers a hep C test. Are there other causes?
Yes, we also have to consider drug-induced lichen planus. Certain common medications can trigger an LP-like rash, things like ACE inhibitors for blood pressure, thiazide diuretics, beta blockers. So if someone presents with a sudden, widespread LP-like eruption, definitely review their medication list carefully.
Okay, now for a major challenge. The blistering diseases. Pemphigus vulgaris, PV, versus bullous pemphigoid, BP. Getting these straight is critical, the sources say.
Absolutely critical. They both cause blisters, but they are fundamentally different diseases in terms of severity, mechanism, and who they affect. Nailing the distinction is key because PV can be life-threatening, while BP is usually more manageable, though still serious.
Let's start with the basic mechanism. What's being attacked in each one?
It all comes down to where the autoantibodies are targeted in the skin's layers. In pemphigus vulgaris, PV, the antibodies attack proteins called desmosomes. Desmosomes are like the spot welds that hold individual keratinocytes, skin cells, together within the epidermis.
So attacking the connections between the cells.
Exactly. This causes the skin layers to split apart within the epidermis, usually quite high up near the surface. This is intraepidermal cleavage.
Okay, high split. What does that mean for the blisters?
Because the roof of the blister is thin, just the upper layers of the epidermis, the blisters are flaccid. They're floppy, fragile, and rupture very easily, leaving behind large, painful, raw erosions.
That was bad.
It is. This fragility also gives rise to a key clinical sign, a positive Nikolsky sign. That's where you can gently rub seemingly normal skin near a blister, and the top layer just slews right off.
Wow. Who gets PV and where?
PV typically affects middle-aged adults, say 40 to 60. And crucially, mucosal involvement is very common. Often the first signs are painful sores inside the mouth or throat, sometimes weeks or months before skin blisters appear.
Okay, so PV recap. Middle age attacks desmosomes, intraepidermal split, flaccid fragile blisters, positive Nikolsky, common in early mucosal involvement. Very serious. Now, bullous pemphigoid, BP.
BP is the structural opposite in many ways. Here, the autoantibodies attack components of the hemidesmosomes. Hemidesmosomes are the structures that anchor the entire epidermis layer down to the underlying dermis, at the basement membrane zone.
So attacking the foundation, not the bricks themselves.
Exactly. This causes a split below the epidermis subepidermal cleavage. The entire epidermis forms the roof of the blister.
What does that mean for the blisters in BP?
Because the roof is the full thickness of the epidermis, the blisters are tense, they're firm, hard to rupture. They might be itchy, but usually much less painful than the erosions of PV.
And who gets BP mucosal involvement?
BP is typically a disease of the elderly, usually people over 60 or 70. And unlike PV, significant mucosal involvement is rare in BP. Patients often have a prodrome, weeks or even months of intense itching, sometimes without any rash, before the tense blisters finally appear. Nikolsky sign is negative.
So BP recap. Elderly attacks hemidesmosome, subepidermal split, tense sturdy blisters, negative Nikolsky, rare mucosal involvement, often preceded by itching. Different picture entirely.
Completely different. And the management reflects this. Because BP blisters are less fragile and the disease often less explosive, you might start treatment with high-potency topical corticosteroids, especially if it's localized. PV, on the other hand, because of the widespread erosions, fluid loss risk, pain, and mucosal involvement, almost always requires systemic corticosteroids, often high dose, and other immunosuppressants right from the start.
That distinction is incredibly high yield. Okay, another immune condition with a specific link. Dermatitis herpetiformis, DH. Sounds like herpes, but it's not, right?
Not related to the herpes virus at all, despite the name herpetiformis, which just refers to the tendency for the lesions to appear in groups or clusters. DH is intensely pruritic, meaning super itchy, but patients often describe more of a burning or stinging sensation.
And the lesions themselves?
They are small papules and vesicles, often excoriated from scratching because the itch is so bad. They classically appear in those grouped clusters, herpetiform, and have a very typical symmetric distribution on the extensor surfaces, elbows, knees, buttocks, back of the neck, or shoulders.
Extensors again. And the critical link here is to the gut.
Absolutely non-negotiable link. DH is the skin manifestation of celiac disease. It's caused by an immune reaction triggered by gluten ingestion. IgA antibodies form against tissue transglutaminase in the gut, and these antibodies cross-react with epidermal transglutaminase in the skin, depositing in the dermal papillae and attracting neutrophils, which cause the inflammation and blisters.
So seeing DH essentially means the patient has celiac disease, even if they have no gut symptoms.
That's usually the case, yes. You must investigate for celiac. The gold standard for diagnosis is actually a skin biopsy of uninvolved skin near a lesion, looking for those granular IgA deposits with direct immunofluorescence.
In management, how do you stop that awful itch and burning?
There's a medication called dapsone, which provides rapid, often dramatic relief from the itching and blistering within days. It's fantastic for symptom control, but it doesn't treat the underlying celiac disease. The definitive long-term management, the only way to potentially cure the DH, is a strict, lifelong, gluten-free diet. It takes months, sometimes years, for the skin to clear completely on the diet alone, but it addresses the root cause.
Another powerful example of the skin-gut connection. All right, we've tackled barrier issues and systemic immune attacks. Now let's shift focus to conditions centered on the skin's appendages, the hair follicles, the glands, things involving keratin and hair. Let's start with the tough one. hidradenitis suppurativa, or HS.
Yeah, HS is a really challenging chronic inflammatory condition. It affects the folliculosebaceous units, basically the hair follicle and associated glands. But it has a very specific location preference.
Where does it typically show up?
It loves the intertriginous areas. That means skin folds where there's friction and moisture. The axillae armpits, the groin, under the breasts, inframammary, the buttocks, areas rich in apocrine sweat glands.
And it's not just simple boils, is it? The progression is key.
Definitely not simple boils. It starts with painful, deep-seated inflammatory nodules. These can progress to form abscesses. But the real hallmark of HHS, what makes it so destructive, is the development of chronic graining sinus tracts. These are like tunnels under the skin connecting the inflamed follicles, and they often leak a foul-smelling, purulent discharge.
That sounds awful. And
Yeah.
it leads to scarring.
Yes. Over time, this chronic inflammation, rupture, and draining leads to extensive, thick, rope-like scarring, which can be disfiguring and limit mobility. It's a really burdensome disease.
What drives this? What are the risk factors?
The exact cause involves follicular occlusion, inflammation, and likely an altered microbiome. But the sources are very clear on the strongest modifiable risk factors. Smoking is a huge one, thought to promote follicular plugging. Obesity is also strongly linked, likely due to increased friction, sweating, and metabolic factors. Metabolic syndrome in general is associated.
So lifestyle changes are important.
Crucial. Smoking cessation and weight management are key parts of the long-term strategy. Treatment itself is typically stepwise. You might start with topical antibiotics, then move to long courses of oral antibiotics like tetracyclines, often used more for their anti-inflammatory effects than killing bacteria. For more severe disease, options include biologic drugs like TNF-alpha inhibitors or even extensive surgery to remove the affected tissue and sinus tracts.
Okay, a difficult chronic condition. Let's switch gears to something very common on the face. Rosacea, often confused with acne.
Extremely common, yes. Rosacea is a chronic inflammatory condition affecting the central face, nose, cheeks, chin, sometimes the forehead. The baseline is usually persistent redness, erythema, and patients can also develop inflammatory papules and pustules.
So how do we reliably tell it apart from, say, teenage acne or even the butterfly rash of lupus?
Two key differentiating points. First, compared to acne vulgaris, rosacea has inflammatory papules and pustules, yes, but critically, it lacks comedones. No blackheads or whiteheads. If you see comedones, it's probably acne, not rosacea.
No comedones, got it. And compared to lupus.
The classic malar rash of SLE, the butterfly rash, typically spares the nasolabial folds, those creases running from the sides of the nose down to the corners of the mouth. Rosacea, on the other hand, usually involves the nasolabial folds. That anatomical location is a subtle but really useful distinction.
And the patient's history is often revealing. Talk about triggers.
Oh, definitely. Rosacea patients typically report specific triggers that cause flushing and flares. Classic ones include heat, hot beverages, alcohol, especially red wine, spicy foods, emotional stress, sun exposure, wind, sudden temperature changes. Identifying and avoiding personal triggers is a big part of management.
And treatment depends on the main symptoms.
Yes, we often talk about subtypes. If the main issue is just the redness and flushing, erythematous-telangiectatic rosacea, treatment might involve trigger avoidance, maybe topical agents like brimonidine that constrict blood vessels temporarily, or laser therapy to zap the visible dilated vessels. If the patient has the bumps and pimples, papulopustular rosacea, the first-line treatment is often topical metronidazole, which has anti-inflammatory and antimicrobial effects. Sometimes oral antibiotics like doxycycline are used in low doses for their anti-inflammatory properties.
Okay, good practical tips there. Now, quickly, let's touch on two other very common, usually less serious follicular things. First, keratosis pilaris, KP, the chicken skin.
Ah, yes, KP, super common. This is basically caused by plugs of keratin skin protein blocking the openings of hair follicles. It leads to these small, rough bumps, sometimes slightly red, but importantly, they're painless.
And the classic location.
The posterior upper arms are the textbook location. You can also see it on the thighs, buttocks, sometimes the cheeks in kids. It often feels like sandpaper. It's associated with dry skin and sometimes atopic dermatitis, but mostly it's just a cosmetic nuisance.
So management is about smoothing it out.
Pretty much. Good moisturization with emollients helps, and then using keratolytics ingredients that help break down keratin plugs like salicylic acid, lactic acid, or urea in creams or lotions can improve the texture.
Okay. And the other one, pseudofolliculitis Barbie, PB Ingrown hairs, basically?
Exactly, but it's a specific type often seen in the beard area, particularly in men with tightly curled facial hair. What happens is, after shaving, the sharp tip of the growing hair curls back and penetrates the skin nearby, or it grows out and then immediately pierces back into the skin.
And the body doesn't like that.
Nope. It sees that re-entering hair shaft as a foreign body, and it mounts an inflammatory response. This causes painful red bumps, papules, sometimes pustules, right in the shaved area. The neck and lower face are common spots.
This sounds like a real problem for people who need to shave regularly for work or preference.
It really is. The management is often about stopping or modifying shaving technique. The best solution, if possible, is to let the beard grow out. If shaving is necessary, advise patients not to shave too closely, using clippers instead of a razor, using a single-blade razor instead of multi-blade, shaving with the grain of the hair growth, not stretching the skin. These can all help minimize the hairs becoming sharp and ingrown. Laser hair removal is also a very effective option for some.
Okay, we're heading into the final stretch now. This section covers the really high-stakes situations, severe infections hitting compromised skin, dramatic autoimmune crises, and life-threatening reactions. Let's start with eczema herpeticum.
This is a dermatologic emergency. Eczema herpeticum is what happens when herpes simplex virus, HSV, usually HSV1, the cold sore virus, infects skin that's already damaged by atopic dermatitis.
So it's the HSV spreading easily because the barrier's down.
Precisely. The compromised barrier of AD allows the virus to replicate and spread rapidly and widely across the skin instead of staying localized like a typical cold sore.
What does it look like? How do you recognize this emergency?
The classic story is someone with a history of atopic dermatitis who suddenly develops a widespread eruption of painful vesicles. These vesicles are often monomorphic, meaning they all look alike at the same stage of development. They quickly evolve into punched-out erosions, often described as looking like someone took a hole punch to the skin. These erosions frequently have hemorrhagic crusts, and critically, the patient is often sick. They have fever, malaise, swollen lymph nodes. It's a systemic illness.
Punched-out erosions and fever in someone with eczema. Sounds scary. Why is it an emergency?
Because the virus isn't just staying in the skin. There's a high risk of it disseminating, spreading through the bloodstream to internal organs.
Oh.
It can cause HSV keratitis in the eye, potentially leading to blindness, or worse, HSV encephalitis, brain infection, or hepatitis liver infection, which can be fatal.
So immediate action required.
Immediate. You cannot delay. Treatment is immediate systemic antiviral therapy, usually with acyclovir or vilaciclovir, often given intravenously in the hospital. You treat this aggressively, like disseminated herpes.
Okay, message received. Eczema herpeticum equals emergency antivirals. Now another concerning one, pyoderma gangrenosum, PG, an ulcer but not an infection.
Correct. PG is a rare, non-infectious inflammatory condition. It's a type of neutrophilic dermatosis, meaning the skin damage is driven by an influx of neutrophils, a type of white blood cell. It causes rapidly progressing, extremely painful skin ulcers.
What do these ulcers look like? Any key features?
They are quite distinctive usually. They often start as a small pustule or nodule that rapidly breaks down. The resulting ulcer typically has a characteristic violaceous border, a dusky purple-red, slightly raised, boggy, and often undermined edge. The base of the ulcer is often purulent, filled with pus and necrotic debris.
And there's that weird feature called pathergy.
Yes, pathergy is crucial. It means that minor trauma to the skin, like a bump, an injection, a biopsy, even sometimes just pressure, can trigger the formation of a new PG lesion or cause an existing one to rapidly enlarge at that site.
What does that mean for management? You can't debride it.
Exactly. This is a huge clinical pearl. Surgical debridement of PG ulcers is generally contraindicated. Trying to cut away the dead tissue usually just makes the ulcer much, much bigger and worse due to pathergy. It's often called the ulcer that hates the knife. Diagnosis is tricky. It's often a diagnosis of exclusion after ruling out infection, vasculitis, etc.
If it's not infection and surgery makes it worse, what's driving it? Are there underlying conditions?
Yes, very strong associations. PG is frequently linked to underlying systemic inflammatory diseases. The most common association by far is with inflammatory bowel disease, IBD, both Crohn's disease and ulcerative colitis. It can occur before, during, or after the IBD diagnosis. It's also associated with rheumatoid arthritis, other autoimmune conditions, and certain blood cancers, hematologic malignancies.
So finding PG means you absolutely have to look for an underlying systemic cause.
Absolutely. A full workup is mandatory. Treatment involves controlling the underlying disease if one is found, and powerful immunosuppression to calm down the neutrophil attack. First-line therapy is often local or systemic glucocorticoids, steroids.
Okay. Now, for the absolute worst-case scenario in drug reactions, Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TSDN, these are related, right?
Yes, they're considered a spectrum of the same disease process, differing mainly in the extent of skin detachment. They are severe, life-threatening, delayed hypersensitivity reactions, almost always triggered by a medication.
How do we differentiate SJS from 10?
It's based purely on the percentage of body surface area, BSA, that shows epidermal detachment or sloughing. SJS involves less than 10% BSA detachment. 10 is the most severe form with more than 30% BSA detachment. The range in between 10 to 30% is called SJS-10 overlap.
What's actually happening to the skin?
It's massive, widespread keratinocyte apoptosis. The skin cells are essentially undergoing programmed cell death on a huge scale, triggered by the immune reaction to the drug. This causes the epidermis to separate from the dermis.
Does it start suddenly?
There's often a prodrome, usually starting 1 to 3 weeks after initiating the culprit drug. The patient develops fever, sore throat, cough, body aches, malaise, feels like a bad flu or infection. Then the rash begins.
What does the rash look like initially?
It starts as ill-defined, often painful erythematous macules, red spots, sometimes with darker purpuric centers, targetoid lesions, but often atypical. These rapidly coalesce and progress to form flaccid vesicles and bullae. Then comes the devastating part. Widespread epidermal sloughing, where sheets of skin detach, leaving raw, denuded areas resembling a severe burn.
And a key diagnostic feature.
Prominent mucosal involvement is almost always present and is a hallmark. Painful crusting and erosions affect the mouth, lips, eyes, conjunctivitis, potentially leading to scarring and blindness, and genitourinary regions. Like pemphigus vulgaris, there's also usually a positive Nikolsky sign due to the epidermal detachment.
Which drugs are the common culprits? We need to know these.
There's a list of high-risk drugs everyone should be aware of. Top of the list often includes allopurinol, used for gout, certain antibiotics, especially sulfonamides like trimethoprim sulfamethoxazole, TMP-SMX, anticonvulsants like lamotrigine, carbamazepine, phenytoin, and some NSAIDs, particularly the oxycam type, but many drugs have been implicated.
And management. This sounds like an ICU situation.
It absolutely is. The first step is immediate identification and discontinuation of the suspected offending drug. Then it's all about intensive supportive care, ideally in a specialized burn unit or ICU. This involves meticulous wound care, fluid and electrolyte management, because they lose fluid, like burn patients, pain control, nutritional support, and preventing secondary infections. Mortality is significant, especially with 10.
A truly terrifying reaction. Okay, let's quickly touch on a few other important rashes that have systemic flags. Psoriasis, we mentioned it earlier, but is there a specific warning sign?
Yes. While plaque psoriasis is common and chronic, the sources highlight that a sudden onset of severe, widespread psoriasis, or perhaps explosive guttate psoriasis, small, drop-like lesions, especially if it's difficult to treat, should raise suspicion for underlying HIV infection. Severe or recalcitrant psoriasis can be a cutaneous marker of significant immune compromise.
Good flag to remember. What about pityriasis rosea? That one causes confusion.
It does, mostly because it looks alarming but is usually harmless. Pityriasis rosea is thought to be a self-limited reaction, possibly triggered by a viral infection, like human herpes virus 6 or 7. It classically starts with a single, larger oval patch, often pink with a fine scale, called the Herald patch. This usually appears on the trunk and might be missed.
Then what happens?
A few days to a couple of weeks later, a more generalized eruption appears, consisting of smaller, similar oval patches. The key diagnostic clue is their distribution, especially on the back. They tend to align along the skin lines, creating a characteristic Christmas tree pattern.
Christmas tree pattern on the back. And it goes away on its own.
Yes, that's the main point. It typically resolves completely without treatment within about 6 to 8 weeks, though sometimes longer. Management is primarily reassurance, maybe some anti-itch lotions if needed.
Okay, last one. IgA vasculitis, which used to be called Hennig-Schönlein purpura, or HSP. What is this?
This is the most common systemic vasculitis in children, though adults can get it too. It's a small vessel vasculitis involving IgA immune complex deposition, often follows an upper respiratory infection. It has a classic tetrad of symptoms.
Okay, what's the tetrad?
1. Skin lesion palpable purpura. These are non-blanching reddish-purple spots, often slightly raised, typically concentrated on the lower extremities, legs and buttocks. 2. Arthritis or arthralgia, usually affecting the knees and ankles. 3. Abdominal pain, which can be severe, colicky, sometimes with bloody stools due to vasculitis in the gut wall. 4. Renal involvement kidney disease, ranging from mild blood protein in the urine to more severe glomerulonephritis.
Palpable purpura, joints, gut, kidneys. How do we confirm it's not something else causing purpura, like a platelet problem?
That's a key differentiator. In IgA vasculitis, the purpura is caused by inflammation and leakage from blood vessels, not by a lack of platelets. Therefore, the platelet count is characteristically normal. If the platelet count is low, you need to think about other causes.
And one specific symptom to watch for in boys.
Yes, the sources mention it can frequently cause scrotal pain and swelling due to vasculitis there, so palpable purpura, especially in the legs, buttocks, plus joint pain, belly pain, or kidney issues with a normal platelet count, strongly suggests IgA vasculitis. Treatment is usually supportive, but monitoring kidney function is crucial.
Wow. Okay, that was a journey. We've covered an incredible amount of ground from, simple dry skin patches and blocked follicles all the way to these massive life-threatening immune reactions and infections.
We really did. And hopefully it highlights the importance of really looking closely. Understanding the subtle differences. Is that blister tense or flaccid? Does that facial rash spare the nasolabial folds or involve them? Those details point you in completely different directions.
It absolutely drives home that the skin is rarely just
Yeah.
skin. It's this incredible window, this early warning system for what's happening deeper inside the body.
It really is. It almost never operates in isolation. If there's a fundamental problem internally, immune dysregulation, infection, systemic inflammation, the skin is often one of the first places to broadcast that message.
Which brings us to our final thought for you, the listener. We've spent a lot of time discussing how conditions like, say, discoid lupus or pyodermic gangrenosum are clearly just the tip of the iceberg, signaling major systemic diseases like SLE or IBD underneath.
Right. But consider this. Given that tight connection, that back and forth between the skin and the rest of the body, what does it mean when even a common skin disease like psoriasis suddenly appears in a really severe, explosive, aggressive form? What is that telling us, not just about the skin's own immune flare-up, but maybe about the overall resilience or perhaps the underlying vulnerability of that person's entire immune system, their whole systemic health? What future risks might that angry skin be predicting?